We would like to share a video presentation of small incision cataract surgery wherein we will showcase a few challenging situations in which we manage the patient with manual SICS. A word about manual SICS. Uh, the most preferred surgery today for cataract is phacoemulsification with a foldable intraocular lens implant. However, there are certain challenging cases wherein phacoemulsification can be risky and can cause tissue damage to the cornea or the posterior lens capsule. In such cases, manual SICS can be a good option. However, it is up to the surgeon's comfort and confidence which can decide about whether to go ahead with the phacoemulsification or manual SICS. The few cases where manual SICS can be preferred are elderly patient with poor pupillary dilatation or with suspected zonular weakness or with phacomorphic glaucoma, where we feel that we have to use more energy for phacoemulsification, which can cause decompensation of the cornea. In such cases, manual SICS can be a good option. So we will start with the first case. I'll explain all the steps of small incision cataract surgery in this case, and also mention what problems can arise at every step and to avoid them. Uh, do take a superior rectus because that will help in the nucleus removal later on. After doing a conjunctival peritomy, do a bit of cautery. uh, Only the conjunctival vessels which are bleeding. Don't do extensive cautery because that might induce astigmatism and cause tissue burn. Normally I take 5 to 5.5 millimeters of the scleral bite or the scleral incision with 2 millimeters of back pocket, something which Michael Blumenthal had suggested in his technique of SICS. However, I don't do the Blumenthal technique completely. I do a visco expression. The most important step is the scleral tunnel. You have to have a good tunnel and AC entry so that you have a 3 planar incision which will be self-sealing. If you need a good intraocular pressure for this, so take a side port and inject visco so as to form the intraocular pressure. Ensure that the crescent is new because that will cut as per our desire, and also that it goes at the desired depth. It should not be too deep and it should not be too superficial, because if it is too deep it will cause iris prolapse, and if it is too superficial it will cut through the cornea. Also do a proper dissection in the scleral tunnel because the nucleus gets engaged there easily, and it helps in delivery of the nucleus easily later on. Also, because the external wound is smaller, the wound remains tight and the inner lip might be larger because of the back cuts which we have created. Now this was a brown to black cataract, so we did a capsulotomy or a can opener. In this case, ensure that it is complete and of the adequate size. This is the keratome which helps in creating the inner lip. Ensure that we cut when we are coming out and not while we are going in. Then the nucleus is prolapsed along with the hydro procedure. In this at this step we use a larger saline cannula which is also called the Blumenthal cannula, and then we try to deliver the nucleus, but the nucleus is not getting engaged. Perhaps the inner lip has to be enlarged a bit compared to the size of the nucleus. Once the nucleus is delivered, we can also prolapse the epinucleus. As it is a mature cataract, most of the lens matter has come out. Then we put a rigid lens, a PMMA lens. Ensure that it goes into the sulcus and also behind the capsulotomy margin. That ensures that it will not rub on the iris, and post-operative uveitis will be minimal. So this was a case of a 85-year-old gentleman with phacomorphic glaucoma. He had a preoperative intraocular pressure of around 40 Uh, we have already done mannitol, intravenous mannitol, to bring down the intraocular pressure. But the moment we entered through the side port, the iris started prolapsing. We have already taken the superior rectus. Because the iris was prolapsing from the side port, we thought that doing a capsulotomy or any maneuver from the side port will be very challenging. So a scleral tunnel was done as mentioned in the previous case, but the moment I entered through the side port with the capsulotomy needle, I happened to injure the iris, causing a bit of iridodialysis. So I entered through the main port by creating a small opening, and then I started doing a capsulotomy here of adequate size and ensuring that the capsulotomy was complete. The intraocular pressure was still on the higher side, and there was not much of space in the anterior chamber for any maneuvers. After completing the capsulotomy, we enlarged the main wound with the keratome. Because it's a good three planar incision, there was no iris prolapse from the main port, which was very important. The pressure from the conjunctiva, the blood from the conjunctiva has actually entered the eye now. Then we removed the nucleus by pulling the superior rectus and a visco expression. And we, after removal of the epinucleus, we put a rigid PMMA lens and remove the rest of the cortex and visco with a Simcoe cannula. You can use a bimanual cannula also. So we have this elderly gentleman with hypermature cataract and poor pupillary dilation. We did a scleral tunnel, and the moment we created a nick in the anterior lens capsule, the milky cortex started coming out. So we went ahead and did a AC entry with the keratome and got rid of the milky cortex completely. And because we had already created a opening in the anterior lens capsule, we extended it using Vanna scissor and also created bit of sphincterotomy so that the pupil gets a bit dilated. Nucleus delivery is actually not a problem because the nucleus is not very large and most of the cortex has already come out because it was liquefied. So we put an intraocular lens behind the capsulotomy margin, the posterior capsulotomy margin. Later on, we can remove it with the intraocular scissors.